our last session of the day, and it is the call to action, an introduction and launch of the Fetal Infant Mortality Action Plan. And with that, I'm going to reintroduce Laura Luna Bellucci, Arizona Maternal Health Director and Bureau Chief for the Bureau of Women's and Children's Health, and Martin Celaya, Bureau Chief for the Bureau of Assessment and Evaluation. These two individuals have provided leadership and collaboration for the development of the Arizona Fetal Infant Mortality Action Plan, along with Sean Sumilis, who is their intern. This presentation provides an overview of the plan and concludes with a call to action and opportunity for your involvement. Laura and Martin, welcome back.
So we're here. We're excited to announce our Fetal Infant Mortality Prevention Action Plan, also how we call it the FIMAP for short. As you can tell, this is our 2024 to 2027 plan. Next slide. So we've already been introduced. I am the person on the left, Laura, and you'll get to hear from her a little bit more. We can go ahead and move forward. Like Patricia mentioned, the idea is to provide the background as to how the Fetal Infant Mortality Action Plan came to be. We will look at data, but honestly, we spent a lot of time looking through lots and lots of data these past 2 days. So I'm pretty confident that I'm not going to be sharing anything that you don't already have heard or have not heard already in these past 2 days. So that's going to be a way that we're going to shorten our presentation for today. And then we'll talk about how we designed the plan, what our shared goals, proposed actions, and milestones are moving forward. Now that we've heard a lot about the status of infant and maternal mortality in the States and all the wonderful initiatives that are happening and other initiatives that could be implemented to make further strides. This is a good way to just kind of summarize what we learned in the summit here. And then we'll offer next steps for how we're going to engage in this work. I'm going to pass it back to Laura now.
So the state of Arizona is committed to utilizing proven strategies, collaborative partnerships, and effective resources so babies are born healthy and thriving. It's obviously something that we also like to highlight during our summit is those partnerships that we have in place to do this work. So for years, ADHS with community partners has been tackling maternal and infant mortality by implementing a variety of strategies over the years. So while reflecting on these activities, it was clear that a FIMAP, or Fetal Infant Mortality Action Plan, is integral to coordinate these actions and milestones, also to track outcomes that impact fetal infant mortality and morbidity as we move forward in our work. So this slide is not an all-inclusive list of activities that we have championed and or in partnership led throughout the years. However, these serve as a cornerstone for the work in Arizona, between ADHS and partners. The information and data collected through these various initiatives and programs have led us to the establishment of a Fetal Infant Mortality Action Plan. Similar to our Maternal Mortality Action Plan, the FIMAP was developed based on what Arizona has learned through experience, what Arizona is currently doing well, and what the local and national data and evidence is showing us. The FIMAP is a tool and will serve as a guiding document, supporting our collective efforts to address fetal infant mortality and establish the relationship between maternal and infant outcomes. Martin will further share the various reasons and the rationale for the establishment of the FIMAP.
Great. So we know, based out of all of the information that we've heard today and from here, our collective knowledge, that there are various reasons why we should be having a fetal infant mortality action plan. On the screen are our top reasons for engaging in this work. And I think the important part of this is that we are building off the momentum that we've had as a group of stakeholders, as partners, as providers, as people with lived experiences, to continue to push that work forward into the fetal infant space from maternal health. We decided to publish 2 distinct documents, as these are some strategies to support health in the post-neonatal period, meaning 30 days to 1 year of life. So we're picking up from where the Maternal Mortality Action Plan is not really ending, but is kind of tapering off and then picking it up with the fetal infant mortality action plan is the idea with that. Overall, the evidence and science strongly supports the importance of improving health of birthing people before, during, and postpartum to ensure optimal health outcomes for infants. In addition, one of the priorities for the Title V NCH block grant in the infant and perinatal health population is to promote equitable and optimal care and protective factors for mothers and infants before, during, and after pregnancy. In addition, within the women and maternal health domain, with partner input, another priority was developed to reduce disparities in infant and maternal morbidity and mortality. Lastly, we're seeing more and more from examples of states nationwide that this is the correct direction to move forward with. We must continue to recognize the importance of the mother-infant dyad as they share an intimate biological, social, and psychological relationship. It's no surprise that infant social, emotional, and neurological development is strongly shaped by the bond established between the mother, the birthing parent, and the child. Next slide. So again, this is just, and I apologize, I'm not sure why the data is showing this way, but essentially, we know from our previous study that there is a majority of excess fetal deaths that are attributed to birth weight distribution. In other words, Arizona has too many babies who are being born very low birth weight, as in less than 1,500 grams or 3 pounds and 4 ounces. Having a previous preterm birth comes with 3 times the risk for a mother having another very low birth weight baby compared to women without a previous preterm birth. Data that is displayed on the screen is from the Arizona Child Fatality Review Program. The data is similar that was presented in yesterday's presentation by Kieran Lonnie and shows that the leading causes of infant mortality are prematurity, congenital anomalies, and followed by suffocation, with noticeable disparities when we look through by racial groups. Slide. For premature, we also know that the premature birth rate or the preterm birth rate has been on the increase since 2019, with the current preterm birth rate at 10% currently, which means that 1 in 10 babies are being born prematurely in Arizona. Overall, the preterm birth rate across the United States has increased for the 4th year in a row, and Arizona's 2021 rate is at 10%, which is a 5% increase from 2020. Arizona's preterm birth rate has increased for the 3rd year in a row, and the March of Dimes noted a C letter grade to Arizona for its preterm birth rate. African American babies are born prematurely at 1.5 times the rate of white non-Hispanic babies, and for Native Americans babies, the prematurity rate is 1.3 times the rate compared to white non-Hispanic babies. Next slide. We also know that the Arizona is accompanied by several other states with an infant mortality rate similar to ours. The map that is being displayed right now includes 2020 infant mortality rates by the U.S. Centers for Disease Control and Prevention. On this map, the darker the shade, or the shade of teal or blue, is the higher the infant mortality rate. Arizona is grouped among the states with the 2nd largest range of infant deaths, which is 4.87 to 6.49. We know that portions of the southeastern United States and the Midwest hold some of the highest infant mortality rates in the nation. Next slide. In Arizona, more than 400 newborns every year will not make it to their 1st birthday. While the Arizona infant mortality rate has consistently been lower than the US rate, there are far too many babies dying in our state. Infant mortality is not equally distributed across racial groups in the states, with Black infants holding a much higher rate for infant deaths, followed by American Indian infants. The infant mortality rate for Hispanics and Latinos is comparable to the state average, but experienced a 41% increase between 2020 and 2021. This is the gray line in the bottom chart there on the right. Next slide. Regarding fetal deaths, the fetal death rate in Arizona has remained fairly stagnant the past decade, with around 500 babies being stillborn every year. Almost 50% of these fetal deaths are either a late or term stillbirth of a much anticipated baby. Preliminary data from 2021 indicates that there was a 20% increase in fetal deaths, equating to 700 babies stillborn. And just a reminder, I know this there was a question. All reported include spontaneous and induced termination of pregnancy at 20 or more weeks of gestation, or 350 grams or more, and some stillbirths prior to 20 weeks and of any weight. The number of all reported fetal deaths in Arizona, including late-term abortions in 2020, was 620, a 3.1% decrease from 2019. The annual number of reportable spontaneous fetal losses decreased by 2.5% from 489 in 2019 to 477 in 2020. The fetal mortality rate increased slightly from a rate of 6.1 deaths at 20 or more weeks of gestation per 1,000 live births in 2019 to a rate of 6.2 in 2020. Perinatal mortality refers to the death of a fetus of at least 28 weeks gestational age or of an infant less than 7 days old. The perinatal death rate per 1,000 live births has been below 6 deaths per 1,000 since 2009, then increased at 6.5 into 2014. The perinatal mortality rate of 5.6 in 2020 represented a decrease from the 2017, 2018, and 2019 rates. Early infant deaths accounted for 211 or close to 50% of the 434 perinatal deaths in 2020. Right. We know that there continues to be disparities around stillbirths, with Black women and Native American women in Arizona being 2 to 3 times more likely to experience a stillbirth compared to white and Latina women in our state. Next slide. To address current obstacles and health disparities in Arizona, the FIMAP will apply the following frameworks: a life course theory, the health equity framework, and family and young adult engagement. The life course theory, also known as LCT, is a multidisciplinary approach that comprises 4 concepts: timeline, timing, environment, and equity. The LCT acknowledges that there are critical or sensitive periods of development when exposure to various events and experiences, harmful or positive, can have a significant long-term impact. Women's health before, during, and shortly after pregnancy is directly related to fetal infant health. In addition, the Health Equity Framework, HEF, illustrates how social and economic conditions affect health outcomes. The HEF relates to the LCT by highlighting that health inequities are the result of cumulative experiences throughout a person's lifespan. ADHS defines health equity to mean that everyone has the opportunity to define and achieve good health for themselves. Finally, family engagement plays a vital role in the maternal and child health programs in Arizona. Family partnership is defined as patients, families, their representatives, and health professionals working in active partnership at various levels of the healthcare system, direct care, organizational design and governance, and policy making to improve health and healthcare. Next slide. This is just a depiction of what we mean by family engagement. You can see that by engaging families and individuals with lived experience, will just overall increase the quality and the importance of the work, but also help us achieve our expected outcomes. Next slide. We spent a lot of time during this summit learning about the health inequities that persist in our state and some of the root causes of it. Therefore, it is critical that an equity framework is embedded into the planning, design, implementation, and evaluation process of this plan. The image that you see there is from another state's infant mortality reduction plan, where they highlighted how social determinants of health and inequities can further exacerbate or improve outcomes for mothers and infants. The image here displays our approach for designing the FIMAP. You can appreciate on the first 2 boxes on the top that actions set forth in the plan are based on state data and evidence. We use the data and recommendations from the Child Fatality Review Program's annual report as a launching pad to conduct extensive literature reviews in academic journals, governmental reports, expert opinions, and other great literature to come out with the list of goal statements that you see at the center of the screen. We then applied various aspects of our 3 aforementioned frameworks to organize our goals, and later sifted through multiple action plans from various parts of the department to optimize alignment of strategies and efforts. This approach took us a year to complete, but we're now very excited to share the plan with you. Next slide. But before we do that, I'll just show you a little bit more about our journey here with the FIMAP. The FIMAP table was developed back on October 15, 2022. Shortly after that, we were fortunate to onboard an intern from ASU's College of Health Solutions, Sean Similas, who you heard from earlier, to help us move the plan through the design process. Sean brought her own lived experience and awareness from her professional associations to further strengthen the plan and produce the narrative form of the plan that we will be sharing with you today. On March 3rd, we held an internal partner meeting with ADHS programs to review the action plan table and solicit feedback. And then on May 22nd, we held an internal ADHS fetal infant mortality work group kickoff meeting with staff that will co-lead and support this effort for sustainability. Laura will be discussing this in more details towards the end of the presentation. On June 8th, ADHS held 2 external partner meetings and invited several state and national experts to get a sneak preview of the FIMAP and solicit additional feedback. Some of the people that attended the meetings are here with us at the summit, and we'd like to express our gratitude for your feedback and wonderful suggestions. This brings us to today, when we are kicking off the plan at the conclusion of this summit. Next, please. The structure of the plan is based on a template provided to us by the department's Office of Strategic Initiatives. For each plan, there is a goal statement, which is depicted in the blue box. Under each goal statement, there are identified needs and benchmarks to document how we plan to document success or to, record success in achieving the goal, depicted in orange. Under each identified need, there are proposed actions, which are essentially strategies, depicted in green. Each proposed action is accompanied by the initiation year, milestones, which can be considered the specific tasks that are needed to achieve a proposed action, and external partners identified that we can hope to engage in this work with. Next slide. This is just an example of what the plan looks like. For our first goal of reduced prematurity in preterm births, we identified a need that prematurity is the leading cause of death for infants, and the percent of preterm births each year is our metric as how we will monitor success or in this goal, in this area. Under that, we identified a proposed action, which is partner with the March of Dimes to establish the Healthy Babies Are Worth the Wait chapter in Arizona. Within that, you see that our initiation here is 2023. Our milestone was to establish a local chapter here in Arizona, and our partner that is identified is the March of Dimes. This is the general structure of the FIMAP. Next, I'll pass it over to my colleague Laura, who will walk us through this different strategies, goals.
At this time, we will move into reviewing the goals shortly, but before that, a thorough review of current data and other state action plans, as Martine had mentioned, specifically those of Alabama and Michigan were used to kind of reference and gather information. It helped to determine the following goals for the FIMAP. So this is a 3-year plan. The department will reevaluate progress annually to make necessary adjustments to the plan and to ensure success. This will allow for the plan to adjust to changing trends or conditions. And we will be using the infant mortality rate as reported by the Arizona Child Fatality Review Program as our benchmark to demonstrate if we are making a difference in reducing infant mortality in Arizona. Through collective impact on all 6 goals, we aim to reduce infant mortality by 5% in 2026 and by 10% in 2027. This translates to roughly 60 to 80 prevented infant deaths. So now we will move into the review of each goal, the data that supports the goal, and highlight just some of the proposed actions and milestones. Our presentation today is not going to cover the exhaustive list of actions and milestones due to the time constraints and the full day that we've had. But the full report will be made available after the summit. It will be published and available to partners and stakeholders to take a full look. So starting with goal 1, reduce prematurity and preterm births, and Martine will cover a few of the data points for this goal.
This will be quick, and I just shared the plan on the chat so folks can kind of follow along if they need to, or if they had any questions about any strategies that may not be on the slide itself. I'm pretty sure you'll find it in the plan. It's a very comprehensive plan. So for our background data, as to help build this goal, we obviously, how we said, 1 in 10 babies are born preterm in Arizona. And this rate has been increasing. So we are using the March of Dimes report card as the basis for tracking success in this goal.
So some of the proposed actions in 2024, as Martine had mentioned, one of them is to partner with the March of Dimes to establish the healthy babies are worth the wait. Also to increase awareness of the risk factors of signs of premature labor. Also taking a look at STIs, so preventing, detect, and treat maternal STIs. Also improving oral health status for pregnant women and expand the use of Arizona Smokers Helpline. So again, these are just some of the proposed actions that we're highlighting. We're not going into full details, and the narrative and the plan itself does provide more detail. Next slide. Some of our proposed actions by 2025, increase the number of women and men and youth who develop a reproductive life plan. We want to look at chronic disease before, during, and after the perinatal period, so partnering with our Bureau of Chronic Disease and Health Promotions. Women at risk for preterm delivery need to be identified and offered access to effective treatments, and reducing non-medically inductive elective inductions of labor. And for goal 1 in 2026, one of the items we want to highlight is that we will also be looking at preventing unintended pregnancies and achieving optimal birth spacing, taking a look and a deeper dive into our unintended pregnancies using PRAMS data. Goal 2, prevent birth defects.
For preventing birth defects are the second leading cause of infant mortality in Arizona, but the leading cause of infant mortality in the US, with 1 in 5 babies dying every year. On average, 111 infants die in Arizona due to birth defects every year. Congenital anomalies that lead to infant death range from neural tooth defects, trisomy 21, and congenital heart defects. The chart on the screen reflects the annual infant mortality rate due to congenital malformations, deformations, and chromosomal abnormalities. The rate has slightly fluctuated over the years, with an average range of 1.9 per 1,000 live births over a 10-year span. The line on the bottom is the infant mortality rate among those with congenital malformation related to brain, spinal cord, or the nervous system. This rate has been stable over the past 10 years.
So in our goal 2 area, proposed actions by 2024, we'd like to take a look at increasing the providers and educators who emphasize pre and interconception care, supporting statewide screening for critical congenital heart disease through support of our newborn screening program and our birth defects monitoring program. Also to partner with our Children with Special Healthcare Needs program and partners to facilitate referrals to local services, expand and promote Power Me A to Z. Additional proposed actions for the following year would be to increase knowledge about primary and secondary birth defects, and also to increase access and utility of genetic counseling services. So when moving to goal 3, strengthen systems of care for mothers and infants.
In 2020, about 1 in 10 Arizona infants, or 9.6% of live births, were born to a woman that was receiving late or no prenatal care. 1 in 5 Arizona infants, 20.6% of live births, were born to a woman receiving inadequate prenatal care. The risk of having a very low birth weight baby is 4 to 5 times greater for women with no prenatal care compared to women with prenatal care.
So for our goal 3, strengthening systems of care of mothers and infants, what we're looking at is enhancing the regionalized perinatal system through coordination with state-funded high-risk perinatal 24/7 consult line and our ongoing partnership with the Arizona Perinatal Trust, specifically to look at the transport components and the consult components of the regionalized system. Also to educate families on insurance options available for mothers and infants to increase levels of health insurance coverage and improve health outcomes, working in partnership with Access in our state. Also to implement the Engaging Families and Young Adults program to assure that families and youth are key partners in healthcare decision-making, that at all levels of the system of care. So really what we'd like to do here is just to continue to do the work that the department through the Bureau of Women's and Children's Health has developed to have a active opportunity for families to engage in maternal and child public health funded activities. For our next proposed actions, looking at consult with Title V family advisors to provide technical assistance to any of our new advisors that we are looking at onboarding through our family and youth engagement program. For 2025, we're looking at exploring opportunities to establish a perinatal nurse navigator program, reduce late entry into the prenatal care by establishing a prenatal care in-group setting program, support the implementation of birthing-friendly hospital designations, which is something that we'd like to explore, increase the use and quality of well child visits, so continue to look at partnering with Kids Care and or other state partners to be able to improve our well child visit. For 2026, a proposed action we want to highlight is support and initiate collaborative quality improvement efforts in the areas that affect prenatal and infant care in the hospital settings, partnering with our AIM steering committee and continuing to look and explore for opportunities there. And in 2027, looking to expand birth options, so partnering with Medicaid to provide, looking at the market value reimbursement rates, obviously having discussions for those particular services around nurse midwives, doulas, and other alternative healthcare providers. And moving to goal 4, diversify and strengthen the workforce.
Here you go. Here what we know already, that the composition of the physician workforce in the US and in Arizona can be improved to reflect the patient population that needs it the most. Here in specific to Arizona, the data that are presented here are for all physicians, and so not specific to folks working and birth workers or OBGYN. So this is all physicians included. Here in Arizona, white physicians make up over 65% of the workforce in Arizona, while only 3% of physicians are Black and 8% are Hispanic, with much smaller numbers for Native American physicians who identify as Native American. Just to give you a little bit of comparison, the percentage of physicians that are considered people of color in the US is 35.4%, and in Arizona, that is 34.4%, which includes family physicians, ED docs, and specialists. Therefore, increasing the diversity of the physician workforce to reflect the population served in Arizona would improve and promote equitable care. The March of Dimes, in partnership with Surgo Ventures, examines determinants of maternal health using the Maternal Vulnerability Index that was presented yesterday. The MBI is the first county-level national scale tool to identify where and why moms in the US are vulnerable to poor pregnancy outcomes and pregnancy-related deaths. The MBI includes not only widely known clinical risk factors, but are also key social, contextual, and environmental factors that are essential influencers of health outcomes. Differences in counties are measured using numerous factors broken into 6 themes: reproductive health care, physical health, mental health and substance abuse, general health care, socioeconomic determinants, and physical environment. The MBI assigns a score of 0 to 100 to each geography, where a higher score indicates greater vulnerability to adverse maternal outcomes. And here on the map for Arizona, you can see that Apache, Navajo, and Gila counties are the areas with highest vulnerability. For Arizona, our MBI score is considered high at 70, and our areas where we could do some work in to reduce vulnerability of our populations are in the reproductive healthcare theme, which measures access to family planning and reproductive services, as well as availability of skilled attendants, all of which are important determinants of maternal health outcomes, and in the social determinants theme, which includes indicators of educational attainment, poverty, food security, insecurity, and social capital. Next slide.
So for goal 4, diversify and strengthen the workforce, we want to continue to improve access to maternal mental health and child-infant mental health services, provide additional statewide training opportunities for clinical and non-clinical professionals, establish training and certification program for doulas, which again, in establishing this in partnership with those new guidelines through the licensing program, diversify and strengthen the workforce by supporting our state loan repayment programs and other workforce programs administered by our Arizona's primary care office. Next slide. Also taking a look at improving access to midwifery care services and supporting innovative community-based models that promote equity-centered initiatives. Next slide. And goal 5, improve surveillance of fetal infant morbidities and fatalities.
Great. So you heard yesterday from our colleagues Aubrey and Karen, and know that Arizona currently does not have a fetal infant mortality review program. And that is an area where we can learn a little bit more about investigating into the stillbirths that are happening into the state. Fetal and infant mortality reviews play a key role in assessing the contributing factors that cause fetal and infant death, while also providing essential information that leads to intervention strategies. Also in Arizona, we do not have an established surveillance program for neonatal abstinence syndrome that is currently very much in the works, which is a much needed resource in Arizona, as there has been a 41% increase in neonatal abstinence syndrome cases since 2017.
So looking at goal 5 and improving surveillance of fetal infant morbidities and fatalities, one of the main proposed actions for 2024 is for the department to look at establishing a fetal infant mortality review program in Arizona, enhancing our NAS data collection and strengthening our current surveillance efforts, such as PRAMs. And then also securing sustainable solutions to fund our child fatality review programs. And goal 6, promote optimal fetal infant health.
So this specific goal is a lot of our public campaigns or public messaging work. So it is a pretty robust goal. And so I'll here go through the various data points that kind of provided the basis for the types of interventions that we're proposing. For home visiting, we know that per the 2020 Arizona Home Visiting Needs Assessment, there were 2,190 families who received home visiting, or only 4.23% of eligible families and 4.97% of families in need of home visiting services. For sudden unexpected infant death awareness in Arizona, we know that SUID is the third leading cause of deaths for infants. Most commonly identified risk factors leading to SUID were unsafe sleep, objects in sleep environment, and an unsafe sleep location, and poverty. Evidence shows that 99% of SUID cases are preventable, which indicates a need for more comprehensive parent education, provider training, and community outreach. For breastfeeding education, evidence shows that 1 out of every 4 infants receive breast milk exclusively through 6 months. In Arizona, 85.6% of infants are ever breastfed and 58.3% are exclusively breastfed at 6 months. Breastfeeding has been associated with a lower risk of SUID and an overall better chance of survival during a baby's first year of life. For stillbirth awareness, according to the Count Kicks Arizona profile, Arizona loses an average of 489 babies a year due to stillbirth, and with implementation of their stillbirth prevention campaign, 158 babies could be saved every year. For neonatal abstinence syndrome, Arizona has observed a 41% increase from 592 in 2017 to 835 in 2021. For COVID-19 and pregnancy, we know that pregnant women are at increased risk for severe illness and death from COVID-19, compared with non-pregnant women of reproductive age, and are at risk for adverse pregnancy outcomes, such as preterm birth.
So in moving goal 6 forward, promote optimal fetal infant health, as Martine said, this is a robust goal and does have quite a few proposed actions and milestones. So again, these are just highlighting just some of the few. The full plan does, or the full plan does document each of them more widely, but for 2024, we want to continue implementing promising practice and evidence-based home visiting programs statewide. So leveraging existing federal and state funding, also increase community awareness on available tax resources. So supporting efforts around the child care credit, child tax credit, and other resources established. Educate parents on safe sleep environments, continuing our work around ABCs of safe sleep. As you saw earlier today, that launch of the Safe Sleep campaign had already begun early in last year. So we've already started moving some of these actions forward. Also ongoing partnership with our WIC program, Empower Breastfeeding Helpline, to continue to support infants, and also infant at work programs and policies. For 2025, establish or fund a program that helps low-income families afford a crib, that can reduce the frequency of bed sharing. Knowing what we know about bed sharing and how it is associated with a significantly increased risk of sewage. So trying to explore ideas there related to unsafe sleep deaths. Provide training in prenatal care at maternity health centers. Establish a coordinated approach to increase awareness and improve outcomes for families impacted by opioid use and substance use during pregnancy. An expanding partnership between our Office of Newborn Screening and High-Risk Perinatal Health Program to find infants who have not returned for a second blood spot screen. So at this point, that concludes kind of our very quick highlight and review of goals 1 through 6 and some of the proposed actions and milestones. And this work, as we know, is not work that ADHS and or that any of us do alone. This is work that we do with our partner organizations. Many of these opportunities and strategies are within models that currently exist with some of our partner organizations or other state agencies. So at this point, I just wanted to reflect on that and pause and thank all of our partner organizations and groups that advise, guide, and work with the department in addressing maternal and infant mortality. So you may be asking yourselves at this point, and we just kind of wanted to finish up the presentation with asking ourselves, how will ADHS carry out this work? So BWCH, our Bureau of Women's and Children's Health, in partnership with our Bureau of Assessment and Evaluation, will follow the successful structure that has been used to carry out our maternal mortality action plan, which quickly I must add a special shout out and thanks to our Bureau's maternal health team, to our maternal health task force and steering committee, and our tribal maternal health task force members, and all those that contributed to the development of the maternal mortality action plan, for the collective work and for that ongoing work, really laying the groundwork and serving as the model for our Bureau's next step of establishing a fetal infant health task force. So with that in mind, the goal is to convene a group of stakeholders with a vested interest in addressing the underlying factors associated with health disparities in infant mortality rates among American Indians, Hispanic, Latinos, and African Americans in Arizona. There is currently an internal work group, which is our fetal infant health team, composed of myself and Martine, the MCH Block Grant Manager, and representatives from each of our offices within our Bureau of Women's and Children's Health. our injury prevention team, a family advisor who will continue on with us, Sean Sumilas, as well as a lead epidemiologist that will be tasked with helping us keep our data and assessment up to date. So our fetal infant health team will establish a state-focused fetal infant health task force to implement the FIMAP and to monitor and incorporate activities as outlined in the plan, as well as ensure that it is in alignment with our state Title V needs assessment. The Fetal Infant Health Task Force and Steering Committee will discuss, review, and track the FIMAP milestones, also adjust based on our annual reviews, and then the task force will again, just bring together key members to serve on a community-based, action-oriented process aimed at improving services, systems, and resources in Arizona. This is not an ADHS alone plan or initiative. This is a systems initiative. Next slide. So we wanted to just quickly share the next steps. As you can see today, we have officially launched the plan, and next we will publish and disseminate this plan. It did go out in the chat box, but more formally will be offered on our website and shared with stakeholders through our different forms of communication. We will begin to take steps to establish the Fetal Infant Health Task Force and Steering Committee, and our goal is to report progress at our Maternal Infant Mortality Summit, similar to how we provide progress on our maternal health plan as well. So this is our call to action. Please join us in our efforts to establish this Fetal Infant Health Task Force to continue doing the work that we do and that you do, but through a more formal task force and steering committee where we can document and monitor our progress to improve health outcomes for infants, which will also lead to enhancing our efforts to improving maternal health. If you'd like to join us, please document your interest in the summit evaluation form that will be emailed to you by Dave Ryder, our meeting planner, at the end of our summit. Or you can simply reach out to Martine and I if you're already connected to the work through the Maternal Health Task Force, because a lot of these, as we mentioned before, our goals that were developed for the FIMAP are in alignment with our Maternal Mortality Action Plan that was very purposeful and thoughtful. So please, you can also express your interest in participation in the Fetal Infant Health Task Force with the teams on the maternal health side as well. So lastly, we did share other opportunities to get involved. So if there's interest in our maternal mortality review program or our child fatality review program, also please indicate this interest on the summit evaluation form, and representatives from the agency or programs will contact you to confirm that participation. So next slide. I want to not go without taking a moment to acknowledge Sean Sumilas. If you know how to put a little emoji celebration for Sean, who worked with our bureaus, BWCH and Bureau of Assessment and Evaluation, through an internship to write the Fetal Infant Mortality Action Plan and put it into a published use of words for us. So Sean was able to take our methods, our notes, our research, and roadmap and put them into the written plan to publish and share with each of you and all of our stakeholders. So thank you, Sean, for your contributions and the help you provided to the state to be able to develop this formal plan. So last couple slides are really just our references and these fancy QR codes that Martine put together link you to our contact information, and we'll just say thank you very much for your participation over the last 2 days, for the time that you've given us, and for the ongoing stakeholder input as we took time to develop this plan and bring it to you today. Thank you.
Thank you so much. Congratulations to you and your team, Laura and Martine, and Sean, for pulling this plan together. You have a lot of kudos certainly coming in for Sean in the chat. That's great to see. Do you guys have a few minutes to take just a few questions? I do know that Martine, you were responding to some questions that were coming in through the chat. Appreciate that. So these questions are really ones that perhaps were not answered. One of the questions is actually from two individuals asked the same question, Josefina Anderson and Alicia Carvajal. What is causing the high preterm birth rate in Arizona? What are the risk factors?
Sure thing. So we definitely have some information from our child fatality review program when we look at the deaths that are related due to prematurity. And so we have seen an increase in substances being involved, as in like in utero exposure as well. I'm trying to just pull it up so I'm not just kind of making things up here, but let's see. 11% of the prematurity deaths were involved in substance use as well. And some of the main factors have been poverty, premature rupture of membrane, had a previous live birth, not having prenatal care has increased, and advanced maternal age, just some of the risk factors. So I encourage you all to look at the Child Fatality Review Program report. It has all those leading risk factors to provide more insight. In addition to that, as part of our action plan, we do plan to do a more in-depth study into premature births, not necessarily just those that lead into fatality, just to know a little bit more about that. The department does do annual reporting on maternal characteristics of these. And so we're going to take some time to do a little deeper dive and come back to further fine tune our strategies.
This next question reads, is there possibly a correlation between inflation leading to increased stress on meeting social determinant of health needs, impacting the increased prematurity? And that is from Andrea McCluskey.
So there is some published literature, not from Arizona necessarily, but that speaks to the wedgering effect that birthing people and mothers may experience and women may experience during their delivery. And so I do encourage folks to maybe research that information. It's called wedgering hypothesis, to learn a little bit more of what may be contributing to it. I cannot specifically say if that is the case in Arizona because I just have not looked at it. It's a little bit more challenging to look at it from that angle, but there's been published evidence from other sources on it.
Okay, and this will be our last question. We do have some additional questions that we will definitely respond to and capture in the summary document. This question reads, does the plan also include actions to investigate and prevent stillbirths? And that's from Jenny Beaver.
Yeah, so we are hoping that by establishing the fetal infant mortality review program, we will be able to investigate more around the context surrounding the stillbirth that occurred. That's one of those benefits of having these mortality review committees and groups that we can access records and have a more provide a narrative to understand a little bit more than just these were the maternal risk factors, but really understand how the system supported that delivery or not, or that birth or not.
Okay, thank you so much, Martine and Laura. Really appreciate all of the work that has gone into this plan. There's lots of positive feedback coming in as well in the chat, just recognizing this important work.